we have a surgery case presentation on oral cavity cancer by Mr. Raghav, who is a fourth year MBBS student at prestigious Kasturba Medical College, Manipal, who is also a student of our own mentor, Professor Rajgopal Shanai sir, who is a legend himself, and Raghav, who is a very brilliant student who has presented previously also in our platform. And when we requested him to present one more case, he has come up with yet another interesting case, which normally undergraduates doesn't present usually. Oral cavity cancers, that's usually PG level. But let's see how he does today. And thank you for volunteering, Mr. Raghav, and all the best to you for this presentation.
Thank you, sir.
And we are really privileged and blessed to have once again our own mentor and patron of White Army, who is a well-known all over the India, all over among all the surgical students for his permanent contribution to the field of surgery through his well-known popular books. For us, we all, especially I have read all his books during undergraduate and postgraduate as well. They were so nice, very well informed, and very student friendly. That's more important. See, so many books are there, but most of them could not be read only by the students. Okay, that's not useful for the understanding, as well as mainly what's required for a student is to pass the exam, right? Right, Raghav? At this juncture, what you need is not the knowledge, but you want to pass in exams. So this is a combination of both. It's a knowledge also. It's all the things covered in one book. Okay, as well as it's very student friendly. If you read that book, no, when you go to the exam, when the examiner asks the questions, oh my God, this is what I was reading yesterday. The same question, the same order. That's what I felt during my UG. The examiner was asking the question in the same order, as if he has also read the same book and come to the exam. It was seeming like that. That's the best thing about that book. It's not exaggeration. I tell in all my lectures wherever I go. M L Saha sir's Bedside Clinics for Surgery is one of the best books I have ever read, or it's recommended for any students. My personal experience, and I hope most of the other students also feel the same. So once again, welcome. It's been a long time since Sir has taken a class for us.
He did not ask me.
One day back or 2 days back, I requested Sir.
You might have forgot me.
He never says no to White Army, or never says no to teaching, not just White Army, any teaching. He never says no, because he's such a passionate and teacher. And I also love his classes. And Sir's daughter, Dr. Priyanka, is a oncosurgeon now working in UK in NHS. Very good friend of mine, my batchmate. So hope she could have joined us for this class. Once again, welcome to you, sir.
Yeah, please start.
With mentor's permission, we can start the presentation.
Yeah, please. Good evening, Raghav. I think
Good evening,
we can start.
Raghav, present till the end of the history. Then let's discuss the history from the first slide, then the examination and management. Okay, that way.
Yeah.
Here is a 70-year-old gentleman hailing from Davangere, who is a farmer by occupation, presented with the chief complaints of ulcerative growth in the inner aspect of right cheek since 3 months. History of presenting illness. The patient was apparently asymptomatic 3 months back when he noticed the ulcerative growth in inner aspect of right cheek, which was insidious in onset and gradually progressive from a size of around 1 into 1 centimeter to a present size of around 2 into 3 centimeter. It is not associated with pain, not associated with bleeding from the lesion, no history of difficulty in opening mouth, no history of halitosis or excessive salivation, no history of white or red patch in the mouth. No history of loosening of teeth. There is no history of difficulty in protrusion of tongue. There is no history of difficulty in speech. No history of drooling of saliva, difficulty in swallowing, or ear pain. There is no history of any swelling in the neck. There is no history of cough, breathlessness, or hemoptysis, or there is no history of loss of appetite or weight loss. Past history, he is a known case of type 2 diabetes mellitus since 20 years on medication and compliant with the medication. He gives a history of placement of dental implants of left first upper premolar and left second lower molar due to dental caries 6 years and 4 years ago respectively. There is no history of hypertension, bronchial asthma, ischemic heart disease, tuberculosis. There is no history of radiation exposure. Personal history, he gives a history of smoking BD since 50 years, 20 per day, Smoking index of 1050 pack years, history of chewing quid since 35 years, 5 times in a day, each keeping for about 15 to 20 minutes, mostly onto the right gingiva buccal sulcus, doesn't keep the quid while sleeping at night. He consumes mixed diet, appetite is normal, adequate sleep he has, normal bowel and bladder habits, no history of alcohol consumption and no history of high risk behavior. Family history, there is no history of head and neck cancers in the family. Summarizing my case, here is a 70 years old diabetic gentleman, known BD smoker and quid consumer, presented with painless progressive ulcerative growth in the right buccal mucosa for past 3 months with no history suggestive of local or distant metastasis.
Okay, go back to the first slide you presented. Yeah. So the chief complaint is a ulcer in the right side of the cheek. So it's a
Yes, sir.
really short duration of 3 months.
Yes, sir.
Okay. And then next slide. So if in the span of 3 months you said the swelling was the ulcer was 1 by 1 and then become 2 by 3. What do you think? How is this ulcer progressing?
It
Is
is
it progressing
rapidly,
slowly or rapidly?
rapidly it is progressing, sir.
So rapidly progressing. Okay, so you can use the term that is rapid progress in this size of the swelling, which doubled in the span of about 3 months' time. And you see this the ulcerative growth inside the cheek, which is there for 3 months, uh, and then it has doubled in this span of time. You have gone through all the relevant history. I agree. But you see, the most of this patient who has got an ulcer in the mouth, there has to be some discharge from that ulcer. Okay, you got my point.
Yes, sir.
Patient may not have excessive salivation, I agree. But a patient having an ulcer inside the mouth will have some difficulty in dental care. He cannot do the normal brushing or whatever. So, this patient may have some uh, discharge from this ulcer, which might be bloodstained or whatever. So you keep in mind that this patient may have some discharge apart from the normal saliva. Second is you said no white patch or red patch in the mouth. So you should be very cautious about that. He is a heavy smoker and he has the habit of keeping the quid in the mouth. So patients who are smokers, who are having these habits, uh, does not just develop that ulcer straight away. There are some premarital lesions which can come up. So you should be very, uh, your patient might have not this because it's a virtual case presentation. But in the exam, if you find a patient that he has got some stigma of this chronic smoking in the oral cavity, you should be carefully mentioning that also. Okay,
Yes,
next.
sir.
You said that patient has no history of cough, breathlessness, or hemoptysis. In oral cancers, how common is this to spread by bloodstream to the distant site?
Sir, less than 4% chance.
Yeah, so the chance is less. And if at all, if you mention that breathlessness, hemoptysis, once it goes to the bloodstream, where else this can go apart from the lungs?
Bones and liver.
Yeah. So if you are mentioning the distant metastatic symptom, you should also cover this part. He has no pain abdomen, no abdominal distension, no jaundice. He has no recent onset of bone pain. Okay. So your history has covered almost all the relevant points. I agree. Next. Uh, so in the past history, some examiner also sometimes say that hypertension, diabetes, these are not part of the past history. But it should be very clear when you use the sentence. If we are saying right like this, patient is a known case of diabetes mellitus for last 20 years, that means you are saying that he's a known case of diabetes. It's not that you are saying past history of diabetes. I agree to this line. You cannot say past history of hypertension. What you can say, when you are examining the patient, he has not given any history of hypertension over this period of time. You can say the same way. He is not a known hypertensive. That is the way one should express. You cannot
Raghav,
say no history of hypertension in the past.
yeah, what sir
Okay.
meant was, I'll make it simple for you.
Yeah.
Past history means once cured or once done is past history. Okay. So,
Yeah.
hypertension, diabetes, and all cannot be cured. Okay. So, if it is there, you should mention in the HOPA itself. Okay. If it's okay, at the end of the HOPA, you can mention. If it's not there, you can mention in the past history. Okay. But see, for example, in a diabetic ulcer case, you start the HOPA itself with the patient who is a known case of diabetes mellitus for last 20 years on irregular medication presented with okay, if it is a hypertension, if it's really that comorbid, it's important in that condition. You start the HOPA with that comorbidities. That's what sir was telling you. Understood?
Yeah.
Yes, sir.
Next, in personal history, you have given the detailed history of the smoking, which is very important. How is the smoking related to development of oral cancers?
As smoking contains nicotine in it, so because of the presence of bacterial commensal present in the oral cavity,
You
the
see, only
nicotine could
nicotine is
be,
one substance. Apart from nicotine, smoking also contains some other carcinogens.
yes, sir, polycyclic aromatic
Yeah,
hydrocarbon,
yeah. See, not only nicotine.
benzenes,
So the
benzene.
smoking contains some carcinogens. And how does this affect the oral cavity so that there is a neoplastic change?
Because of the action of the bacterial commensal present in the oral cavity, nicotine will be converted into nitrosamines, causing the carcinogenic effect in the oral cavity.
Yeah.
Also, other carcinogens are also present in it, like polycyclic aromatic hydrocarbons, benzenes, butanons, arsenic,
So
ammonia.
this is one mechanism. What else happens? What else smoking can cause which can lead to cancers?
So there is
This
hyperproliferation of the
and second, this smoking induced carcinogens can cause genetic alterations. You see, in oral cancer, there are some specific genetic mutations which can happen, and these patients become prone to develop cancer. Like,
P53 mutation,
yeah,
overexpression of
so
EGFRs.
P50 is a tumor suppressor gene. So if there is mutation in P53, these patients become more prone to develop cancer. And then epithelial growth factor receptor gene. So
Yes,
this
sir.
can alter these genes also. Okay, you said he has a habit of chewing quid. How does this again uh, causes some change in the oral cavity which can lead to cancer? Because I was saying this, a smoker for so many years, uh, for long, such 50 years, and then this chewing of quid, there is no change in the oral cavity is very unusual. There might be some staining because of this quit chewing, because of this smoking. There can be some oral cavity changes that you should uh, try to appreciate. This patient might have some change in the oral cavity in the form of leukoplakia or some erythroplakia. Okay, so these are the things. If it is there, you should not miss that. Okay.
Quid contains betel nut, betel leaf, flyglane, and tobacco. So betel nut has produces the ericolin and tannins, which are alkaloids.
Yeah.
Acetylcholine causes the stimulation and proliferation of the collagen, whereas tannins causes the stabilization of collagen, thereby producing the hyperproliferation causing the cancer.
Yeah. And you said he has no history of alcohol consumption. So patient who is a smoker and somebody who is smoker plus alcohol, how do you think is going to affect the oral cavity?
Only smoking has a risk of around 5 to 10 times than non-smokers. Smoking plus alcohol has 30 to 40 times more risk than
So,
smoking.
so this combination, the alcohol plus smoking, increases the risk to further extent. And you mentioned one point lastly that no history of high risk behavior. Why this history is important in a patient who has got oral cancer?
Because of the human papilloma virus being
Yeah.
transferred through the high risk behavior.
Yeah. So these are important. These HPV induced oral cavity changes can lead to cancers. Okay, and the two strains are important. Like,
HPV 16 and 18.
yeah. So this it should be clearly mentioning in the history, because these are the uh, patient who may have a associated HPV infection, and they may have a higher risk of developing cancers. Okay, next. Not only head neck cancer, you see, a patient who has got P53 cancer mutation, back, the family history, you can just simply mention any other malignant disease in the family is important. So this head neck cancer may have some correlation with other form of malignancy also. So the history of the family should include also any other malignancy in this whole family, not only head and neck. Okay?
Yes.
Okay, fine. Uh, Kishan, I think you can go to the examination.
General physical examination. The patient was conscious, cooperative, and oriented to time, place, and person. Height of 170 centimeters, weight of 68 kgs, BMI of 23.5. He is moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Vitals, pulse rate of 68 beats per minute, regular rhythm, normal volume, normal character, no vessel wall thickening. All peripheral pulses were felt, no radioradial or no radiofemoral delay. Blood pressure of 128 by 86 mmHg measured in right arm in supine position. Respiratory rate of 15 per minute, abdominal thoracic type of breathing. The temperature afebrile. Inspection, oral cavity examination, inspection. Lips and commissures appears to be normal. Mouth opening is adequate. Inter-incisor distance is 42 mm. Buccal mucosa, a solitary ulcero-proliferative growth of size around 2.5 into 2.5 centimeter in the right buccal mucosa, extending anteriorly around 0.5 centimeter posterior to the right commissure of the lip, around 3 centimeter from upper gingivobuccal sulcus and around 3.5 centimeters from the lower gingivobuccal sulcus, and posteriorly extending up to the first molar. Slough present on the floor, everted edges, it has irregular margins. A leukoplakic patch was present around the margin. Left-sided buccal mucosa was normal. Teeth, dentures were placed at left first upper premolar and left second premolar, second lower molar. No sharp tooth was present. Tobacco staining of the teeth was present. No dental caries. Here is the dental formula. Gingivobuccal and gingivo-labial sulcus is normal. Tongue is normal, and gums appears to be normal. Floor of the mouth, retromolar, trigon, hard palate, and soft palate, uvula, anterior and posterior pillars, all appears to be normal. In tonsils, there is no enlargement. Posterior pharyngeal wall normal. Palpation, no local rise of temperature or tenderness. All inspectory findings were confirmed. A solitary ulcerative growth of around 2.5 into 2.5 centimeters in the right buccal mucosa, extending anteriorly 0.5 centimeter posterior to the right commissure of the lip, 3 centimeter from the upper gingivobuccal sulcus, and 3.5 centimeter from the lower gingivobuccal sulcus. Posteriorly extending up to the first molar, everted edges, irregular margin. Induration was present up to 0.5 centimeter from the margin in all directions. It doesn't bleed on touch. By digital examination of the mandible, there is no involvement of the mandible felt. Neck examination, there is no cervical lymphadenopathy. ENT examination, there is no obvious lesion in nasal cavity, posterior part of the tongue, and oropharynx. Indirect laryngoscopy wasn't performed. Scalp and cervical examination are within the normal limits. Cranial nerve examination. On right and left side, all 9, 10, 11, 12 cranial nerve appears to be normal. Systemic examination, respiratory system, normal vesicular breath sounds heard, no added sound. CVS, normal S1, S2 heard, no murmur heard. Or abdomen, normal shape, soft and non-tender, no organomegaly. CNS, no focal neurological deficit. Provisional diagnosis, should I say so?
Yeah.
Probably carcinoma right buccal mucosa, clinically T2N0M0, stage 2. Depth of invasion and extranodal extension has to be determined by imaging aiding in the diagnosis.
Okay. Back to the examination first slide. So general physics examination, you can make it when you present, you can just give an outline of this presentation. And now come to this. You said height, weight, and BMI. Why is this examined? What do you assess by doing this?
Cancer cachexia.
Cancer. That means nutritional status. You mean?
Yes, yes, sir.
Okay. So in that case, you need not mention about height and weight. If you simply say BMI, and BMI also BMI is a numeral. Kg per is not 23.5 kg per square meter. It's a calculation of weight divided by height in square
Height.
meter.
Yes,
So
sir.
if you say BMI is 23.5, it is clear what you are trying to mean. Is it clear?
Yes, sir.
So it is not 23.5 kg per square meter. Kg per square meter is the calculation you are arriving at. And the BMI indicates the nutritional status. Okay. So when you comment about BMI, how else also you said moderately built and nourished. So what are
Based
the
on
parameters? What are the parameters you examine to comment about the nutrition? Because these are the patient. This patient does not have restriction of mouth movements or tongue movement, so they can take normal diet. But most of the oral cavity patient has some restriction of swallowing, some restriction of tongue movements, so they may have some nutritional issues. So how do you assess nutrition of a surgical patient?
based on the amount of the calories that the patient takes and input and
I mean,
output.
clinical examination. You are doing clinical examination. How do you comment? You said the is patient is moderately nourished.
Yes, sir. Based on the weight of the patient and the waist hip ratio and skin fold thickness.
Start with the basic thing. The first thing is general appearance. When you look at a patient, the patient may look emaciated. Clear. He may have malar prominences. You look at his chest, you can see the ribs clearly, wasted. So the patient may look emaciated. That is the general look of the patient. Or if you look at a patient, he is average build and good amount of nutrition, you don't find these changes. Okay? First is general appearance. Second is muscle bulk. Muscle bulk.
Yes, sir.
Okay? Muscle bulk you assess by medium circumference.
Madam, sir.
Next is fatty content of the body. You assess by
Abdominal circumference,
no,
waist,
no, no, not that.
waist.
Triceps skin fold thickness. Triceps skin fold thickness. You just pinch the skin. If the patient is emaciated, you just feel the skin in between your fingers. In an average patient, you find there is some fat in between, and you can also measure this skin fold thickness. So muscle bulk, skin fold thickness. Next comes your BMI. Okay,
Yes, sir.
patients who are malnourished may have some micronutrient deficiencies. How do you assess that? Micronutrient deficiencies
They, I don't know.
means I mean the micronutrient means vitamins. So patient may have some eye changes.
Hmm.
There may be dry eye. Okay, there may be dry eye.
Yes, sir.
Patient
Night
may have
blindness.
angular stomatitis. Patient may
Yes,
have glossitis, red smooth tongue. Okay,
yes, sir.
so these are the situations that you can assess to assess nutrition. BMI is the uh, objective assessment. You understand? The
Yes, sir.
remaining what you discussed, our subject, you said patient has got this eye change. I say no, it doesn't look like that. So these are subjective. BMI is the final objective assessment of the patient nutrition. So to comment about nutrition, you should also examine these components. And when in general examination you comment about the lymphadenopathy, here lymphadenopathy is more important because you have to include this in the local examination also.
Yes,
Okay?
sir.
Okay, next. This is the examination where you do an inspection. You ask the patient to open the mouth and assess the mouth opening. That is why mouth opening is important.
Difficult. There can be some difficulty in mouth opening.
Why?
That is not because of the involvement of pterygoid muscles by.
Yeah. So this can be either a muscle spasm or it can be direct infiltration of the growth into the pterygoid fossa and the muscle itself. So if the mouth opening is restricted, it will be difficult for you to examine the oral cavity. So this mouth opening is important. Next, you have described this uh, ulcerative growth. Okay, next. Dentures, gingiva, sulcus, tongue normal, gum normal. Next. So what are the other areas? Why do you need to examine this area in the oral cavity? And you said buccal mucosa, or if you can say cheek. So what are the areas in the oral cavity? What are the areas in the oral cavity you examine? You have examined all these areas. Why this area examination is important?
Because of the concept of field cancerization, sir.
Yeah. So these are the patient who has got, these are the patient who has got some changes in the oral cavity, and they may develop a cancer in other sites. At the same time, you may have field cancerization. So these are the areas you should examine properly. Okay. Next.
Yes, sir.
Uh, when you examine the oral cavity inside, you examine with your bare finger, use a gloved finger.
Glove finger.
Then if you use a gloved finger, how do you comment about the temperature? You did not mention that. Okay, make it clear that a patient has got an ulcerative growth inside the cheek. And here is a gloved finger, the comment about temperature is not required. Okay, that is not important. So you cannot assess also. If you are using a gloved finger inside your oral cavity, you cannot appreciate the temperature. And in ulcerative growth, the temperature change is also not a very significant factor to say it's a malignant ulcer or a benign ulcer. Clear? Because the other features of the ulcer is important here. Otherwise, the description is good. Next, you said the mandible is not involved.
Yes, sir. Not
How
involved.
do you ascertain the mandible is not involved?
By the bidigital examination, sir.
Before
One
that,
thing,
before that, you
mobility
have
of the.
described the ulcer.
Yes,
You
sir.
have not said the ulcer has reached into the gingival sulcus. For the mandible to get involved, if you find there is healthy mucosa in between the margin of the ulcer and the mandible, it is unlikely that mandible will get involved. Okay, so that is the first thing. To comment about the mandible or the maxillary involvement, you have to see that whether there is a healthy mucosa in between the margin of the ulcer and the bony part. That is one, and then you do the examination. Clear?
Yes.
And when you go for the ENT examination, you said posterior part of the tongue and oropharynx. Okay, so
Yes.
even the whole posterior part of the tongue cannot be examined by just a mouth opening. Clear? So for proper examination of the posterior part of the tongue and the uh, oropharynx, you might need to do a laryngoscopy examination by using a mirror. Okay, so that you can mention that I have not done a mirror examination. I just inspected the oral cavity, and you mentioned about the other sides. That part is fine. Up to that is fine.
Yes, sir.
Next,
Raghav, go back to one second, sir.
yeah,
Go back to previous slide.
yeah,
Previous to this. Previous to this. Yeah,
yeah.
here you mentioned about the induration. What does this infers? What do you why you're interested about induration? What does it signifies?
Induration is more commonly present in malignant ulcers. That is characteristic finding in the oral cavity.
The induration means what?
Means what?
It it is the host response that is showing the good host response by the body, causing the thick fibrosis of the uh, area around it, delaying the spread of the tumor to the uh, other areas.
No, no. Induration is not only fibrosis. Try to understand.
Infiltration.
Induration is not only fibrosis. Induration means if you are talking of cheek, you have mucosa. Deep to the mucosa, what do you have?
Some mucosa.
Deep to the mucosa, you have buccal pad of fat. Deep to that, deep to that, muscles of the face.
Muscles of the face.
And then outside is the skin. So this ulcer starts where? In the mucosa. And once you have a malignant ulcer, what happens to these cells in the periphery? They try to invade
Yes.
into the adjacent area. So that is what induration is. Apart from the ulcerative area, this surrounding area may have a different feeling than the normal mucosa, and this tumor can invade into the
Yes.
deeper layers.
So induration suggests you of tumor infiltration in case of malignant ulcers. Okay. Whereas in the chronic inflammations and trauma and irritation, it may be because of the fibrosis, like you mentioned. But in the induration is a classical feature of malignancies, especially in oral cavity and all. It suggests you of local invasion there. Clear? Because that's why that margin how much is very important, because we have to excise that also, indurated part also. Okay. Next.
You said you have examined the ninth nerve. How did you examine the ninth nerve? Is what? Glossopharyngeal.
Yes, sir.
How you say comment at the right and left and normal. What is the examination you have done?
A taste from the posterior one third of the tongue.
How did you test? In MBBS exam, you are not supplied with anything. So better not mention it. In MBBS exam, you are not supplied with any of the thing that you can ask the patient to test, and because you can take a history that he can sense the taste. In the history, he has not said that he has loss of taste in the tongue because tongue is almost normal. But when you examine, you need to have some material in your hand to objectively test and say that yes, I examined the test. That is not possible. You see, how do you examine kernel of 10?
Then we have to look for the patient is asked to say and we have to look for the movement of the
And
uvula and the soft.
before that, he has no nasal intonation. He has no history of the food going into the uh, respiratory tree. So his closer is good while you are swallowing. He has no difficulty in swallowing. Clear? And then
Yes,
when you examine the palate. Okay, so that is about the
yes.
10. What is comment about the 11?
The 11 supplies trapezius, so we'll ask the patient to shrug the shoulders and we will apply the resistance against it.
Is supply only trapezius? Is there another
No,
muscle?
yes, sir. Sternocleidomastoid.
Yes. So you test for the sternocleidomastoid and the trapezius.
Sternocleidomastoid. Yes, sir.
And you said,
Ask,
uh, uh, do you think patient has got a this ulcer in the cheek and you all the gingival sulcus is free? Is there a chance that it might involve the 12th?
very rarely.
Very unusual, unless you have a cerebral lymphadenopathy, which is large, pressing on the nerve. Otherwise, you see, you have mentioned for examinations, fine, but you should
Absolutely.
understand that if say tongue is normal, no difficulty in tongue movement, uh, his speech is normal, okay, so that way, uh, yeah, it's likely that it's normal. So how did you test for the 12th nerve? What happens? Suppose 12th nerve is paralyzed. What do you find on
So,
examination?
so there will be deviation of the tongue to the same side.
Deviation tongue to the when? In
Sir,
the oral cavity, the tongue is lying in the floor. When
yes,
it
sir.
will get deviated?
So when the patient is asked to protrude the tongue, there will be deviation
Yes.
of the.
So the first thing is, if the nerve on that side is paralyzed, there may be wasting. There may be wasting of muscle on the same side. Number one. And if you ask the patient to protrude the tongue, then only there will be deviation to the same side. Okay. Why? Why is this?
Because of the opposite side genioglossus tends to take
Yes.
the upper hand.
So the genioglossus action is you push the tongue to the opposite side. Okay. Next. 60 is fine. Chalo, next. Yeah, you have given a diagnosis and you try to put the TNM staging also. Okay. So in HSCC 8, what is the change that we cannot straightway give a clear indication of T and N on just a clinical examination? What is the
They
limitation?
have they have added depth of invasion in T staging and extranodal extension in N staging.
Yeah.
Very good.
And the size also, exact size.
Yes, sir.
So if you have a lymph node measurement in hand, you have to measure exactly with the caliper and then you have to comment about the external extension also, which is not possible. But if you have a patient who has got a lymph node enlargement which is fixed, immobile node, that indicates that it's a locally infiltrative lymph node. That indicates external extension. Otherwise, now you can say that the clinical staging is possible after biopsy and on investigations. Once you do the investigation, you have these parameters in hand. Okay, fine. So, what you say it's a probably a carcinoma of the right buccal mucosa. Why do you say it is a malignant ulcer? Why do you say this ulcer you are dealing with is a malignant ulcer?
Because, sir, starting from the history, the patient gives the history of chronic smoking and quit consumption from last 50 to 30 to 50 years.
Yeah.
And also it is a rapidly progressing ulcer. That is, it was started at 3 months and it has progressed in double in size in 3 months. On the basis of examination, on examination, it has everted edges. Induration is present around the margins and suggested of carcinoma right buccal mucosa.
So you have already mentioned it's an irregular ulcer. It's
Irregular.
not a punched out smooth ulcer. It's an irregular ulcer with a everted margin, and there is mild induration around the margin of the ulcer. Okay, so these are the characteristics of a malignant ulcer. What else may be the cause of such oral cavity ulcer apart from a neoplastic ulcer?
They can be, sir, tubercular ulcer.
Yes,
Aphthous ulcers could be there.
aphthous ulcer is aphthous ulcer. You should not bring into the DD of this patient. You see, when I asked you this question, you have given an ulcer description in this patient.
Yeah.
What may
Yes.
cause a ulcer which may mimic this ulcer? Aphthous ulcer is totally different.
Dental
Aphthous
ulcers.
ulcers has multiple superficial ulcers.
All the features should match, almost all, not if not
Okay, you
everything.
say tubercular, I agreed. What ulcer may have a similar feature like you are looking at this patient?
Dental ulcers.
Yes, dental means traumatic ulcers.
Traumatic ulcers.
Okay, the patient who has got a sharp teeth or patient are using dentures may have
Typical.
dental ulcer. Okay, so simple bacterial infection. Simple bacterial infection is said tubercular. Apart from this, a non-specific bacterial infection can cause ulcer. Okay,
Yes, sir.
so this is a patient and you have given a diagnosis of a neoplastic ulcer. So how are you going to proceed in this
One
patient?
second, sir.
Yeah.
If this your ulcer, if it's extending into the floor of the mouth,
Yeah.
what happens to your staging?
It will be changed to, sir, T4A.
Very good. If the same thing is involving the or covering the internal carotid artery,
T4B.
so here it is not the size which matters. Okay, if it is locally advanced or if it is removable, accessible, then it is T4A. That's what the understanding, and those are the commonly asked MCQs as well for you. Okay, if it is involves a structure which cannot be removed, like pterygoid plates, masticator space, or even the base of the skull and all, it becomes T4B.
Yeah.
Which if it involves a local which can be removed, then it is T4A. That is a good understanding you should have. Okay, good. Next, sir has asked, how do you go about?
Yeah, okay, then fine. Then you can discuss a little part of this. You say C2, CT2. What does T2 here means?
The tumor dimension is a tumor in the greatest dimension of size more than 2 centimeters but less than 4 centimeters, and depth of invasion being between 5 to 10 mm.
But that is difficult to assess clinically. Okay, that is investigation to assess the investigation depth. Okay, fine. You said N0. What is
There is
N1 in oral cavity cancer?
N1 is single ipsilateral nodes size of less than 3 centimeters.
And no external.
No external extension present.
Okay, fine.
So there is absent.
Yeah. And N2? N2 has
N2
N2A, 2B, 2C.
N2 has N2A, B, C. A is single ipsilateral size of the swelling, size of the lymph node being 3 to 6 centimeters. External extension is not there in that
Yeah.
also. N2B is multiple ipsilateral, node size of less than 6 centimeter. Extranodal extension is absent in this as well. N2C is bilateral or contralateral,
Very good.
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 single or multiple. Size of the lymph node is less than 6 centimeter. Extranodal extension is absent in this one also. T3
Yeah.
is divided into T3A and T3B. Sorry, N3 is divided
Yeah.
into N3A and
Yeah.
N3B.
Yeah.
N3A is nodes of more than 6 centimeters. Extranodal extension is absent in this as well. And N3B is node size of more than 6 centimeters, but extranodal extension is present.
Very good. Very good. You're answering like
Commonly asked is N to C, okay, for you in exam, because they'll just give there's a left-sided tumor is there, and all. Then in the below they mentioned right-sided this lymph node is present. You will not make out it left and right. Okay, you just see the same lymph node is there.
yeah.
Okay, that is N2C. It's a contralateral lymph node. So side
Yeah.
is very, very important there. Okay, if it is a N2 is most commonly asked question for to confuse you. Good, good, Raghav. Very good.
Good. Very good. Okay. So that being your provisional diagnosis, how are you going to proceed with this patient?
I would like to confirm my diagnosis. I would like to confirm my diagnosis and then stage the disease and then routine workup, sir.
Fine.
So
That's good.
go as my lesion is big enough. So I would like to go with the imaging first, followed by biopsy. So I would go with MRI, head and neck, and ultrasound of the neck.
No, 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 no,
Followed.
no, no, no. No. You see, the approach should not be imaging first. Try to understand. You say tubercular ulcer. You say bacterial ulcer. If you do a biopsy and you find tuberculosis, do you think MRI of this area is required?
No, sir.
So the approach in such patients should be a confirmation. How do you confirm? If you are going to do
Veg.
imaging will not confirm your diagnosis here. The confirmation of diagnosis in this patient will come from biopsy. So the first workup should be biopsy. How do you take a biopsy in this patient?
I would like to take, sir, veg biopsy
From where?
from the edge of the ulcer.
Why? Why do you take a biopsy from the edge of the ulcer, not from the center?
Because the edge of the ulcer will have the maximum proliferation of the cancerous
Very
cell.
good.
So I
Very
would like
good.
to take it from there. And also we would take the normal and the diseased portion of the ulcer, thereby comparing
Okay.
between the two.
The most important is the most proliferating margin of the ulcer is this at the junction. So that's why I take a. It's not that comparing normal and malignant tissue is not required for a pathologist. He can make out the malignant tissue and the normal tissue. Okay. So your idea is to take a biopsy from the edge because that is the most proliferating margin and diagnosis become obvious on that side. Fine. So you did a biopsy, and biopsy came as a well-differentiated squamous cell carcinoma. Okay, is this the commonest or something different is there?
It is the most common one.
Common. What other histological type may be there in this area? Malignant tumor,
Adenocarc- Adenocarcinoma could be there.
adenocarcinoma may be there. Yes,
Then melanomas could be there.
yes,
Sinonasal melanoma or oropharyngeal melanomas.
yes. Melanomas. What else? A well-differentiated squamous cell carcinoma is one variety. There is another
Verrucous
squamous cell
carcinoma.
variety that is
Verrucous carcinoma.
varicose. What is the characteristics of varicose carcinoma?
It is a slowly progressive small cell carcinoma, well differentiated one, which rarely metastasizes with
Yeah.
the lymphatics, also known as Ackermann's tumor.
Okay. Okay. Then you have a diagnosis of well-differentiated squamous cell carcinoma in this chick. And what next?
I would like to go with the imaging then.
What imaging? Why is imaging required?
Sir, so for the T staging, I would like to go for MRI of the head and neck. For N
Yeah.
staging, I would like to do the ultrasound of the neck. For M staging, as it is T2, I don't think so. CT would be of the chest would be required in that case.
Yes. If the lymph node is not positive, a full workup with just CT may not be required. Okay. But a
Yes,
lymph
sir.
node positive disease means you have to investigate further.
And then ENT examination has to be done. That is indirect laryngoscopy. And for checking the upper GI tract, upper GI endoscopy has to be done for looking for the
If you have a
precancerous.
if you have a suspicion of mandibular or maxillary involvement, what other imaging may help?
CECT head and neck,
CCT or initially a orthopentamogram.
orthopentamogram.
A orthopentamogram may help.
X-ray
Okay.
first. Then Raghav, why you told radiological first? Then how do you substantiate that? You told you'd get imaging first, then biopsy. How do we substantiate that? Why do you say so?
Sir, because sir, if the lesion is a bigger one, and if I would take the biopsy first, maybe maybe the imaging could show arbitrary, no sir, arbitrary results.
No, see, you are not sure that it's still malignancy, right? If it's a simple tubercular ulcer, how your imaging will help you?
Yes, sir.
Okay. Once you confirm that malignancy, then to know the invasion only you are getting imaging, right? Otherwise, imaging of no use if it's a tubercular ulcer or if any traumatic ulcer. Am I right?
Yes,
Because
sir.
that's what servers. Okay, you see in breast and all we do imaging first because that it loses its architecture. That's why you get imaging first. That's the answer usually given. Okay, but sir, what sir was expecting you understood. No, first prove your diagnosis that it's malignant because there are so many close DDs are there. Without proving that it's
Yes.
malignancy, you go to see the invasion and all. And why MRI? Why you say it's MRI of the head and neck? Good answer. You are answering really well. So we are asking in depth. Okay.
That to look for
MRI is
the
better than CT.
because we have to in the diagnosis. I would like to have the depth of invasion. So depth of invasion would be seen better on MRI because
It's a soft tissue tumor. It's a soft tissue tumor. This is a soft tissue tumor.
Yes, sir.
You got my point?
Any
So
soft tissue dealing
when
with
you do imaging, and you have something in mind that I like to see the soft tissue architecture, or you want to see that bony involvement, so how do you decide, MR or CT?
Sir, if I would like to see the bony involvement, then I would like to go with the CT. And if I want to see for the soft tissue, then I would go with MRI. So in MRI, I would like to see the
Good.
base of the skull involvement, internal carotid artery involvement, and all the
Perineural
nearby
invasions, all those
perineural invasions.
Yeah.
All of that area. And if the mandible involvement I would like to see, I would see it in the CECT, or I would previous to that OPGA can be done. That can help.
Good. Good. So this patient, you said you'll do ultrasound of the neck to assess for the metastatic node.
Yes, sir.
What node are likely to get involved in a patient who has got a cheek cancer?
So level 1B and level 2.
Level 1B and level 2. What are the different levels of node in the neck?
So it could be divided into 7 levels. So level 1 has level 1A and level 1B. Level 1A is submental, 1B is submandibular.
Yeah.
Then level 2 is upper deep cervical, level 3 is middle deep cervical, level 4 is lower deep cervical, level 5 is posterior triangle, level 6 is pre and para laryngeal lymph nodes, and level 7 is mediastinal lymph nodes.
Yeah. When you said upper, middle, lower, 2, 3, 4, what are the approximate demarcation?
Level 2 is from the base of the skull to the hyoid bone. Level
Good.
3 is from the hyoid bone to the lower border of cricoid.
Very good.
Level 4 is from the lower border of cricoid to the suprasternal arch.
And with what relationship they lie in the neck?
They lie in relation to the anterior border of sternocleidomastoid.
Deep to the sternocleidomastoid.
Deep to the
along the
jugular. That's why it's called
jugular vessels.
Yeah,
Upper
along the
jugular,
interjugular vein. So roughly you can say the upper third of the interjugular vein, middle third, and the lower third. That is the approximate demarcation of these lymph nodes 2, 3, and 4. Okay, this cheek malignancy primarily goes to. They can go to level 1, 2, and 3. These are the primary site of spread from the cheek or the oral cavity. And then once the spread occurs further, it can go to the other lymph nodes. Okay.
What is suggestive of malignancy on USG?
Sir, metastatic lymph node on ultrasound would look, first of all, the size would be more than 1 centimeter.
Mm-hmm.
It would be globular in shape. Irregular margin would be there. Loss of fatty hilum. Then bridges in the capsule would be there. Loss of peripheral halo would be there, halo sign. And on Doppler, it will show hypervascularity.
Very good. Very good. Very good.
Very good.
And it may not be always more than 1 centimeter. Okay. If you are talking of groin node should be more than 1 centimeter. The cervical nodes, axillary nodes, even a node more than 7 millimeters is also significant.
Yes.
Okay. So you have done biopsy, well-defined SCC. You have done MRI. This is a localized tumor going from the mucosal margin towards the some muscle infiltration is there. Okay.
Yes.
And then your lymph nodes are zero, N0. So how are you going to treat this patient?
First of all, patient has to be advised to stop smoking.
Yes.
When he is in the positive sense, then in order to prevent the recurrence, we can give the patient nicotine gums, transdermal patches, and all of that, and the patient can be sent for tobacco counseling. Then the good oral hygiene has to
You
be
send him for
advised.
tobacco counseling, he goes for counseling for longer period or what?
No, sir. No.
The patient has come
Anti-tobacco
to malignant
counseling, not
ulcer.
tobacco counseling.
All these will carry on, but he
Yes,
is
sir.
a patient who
Sideways.
already has the end result of his smoking. So he is having a malignant ulcer. So your treatment should proceed at the same time of your asking him to stop smoking, this counseling, everything. So it's not that you send referred to a counselor, go for
He'll never come back.
no. So these are all important. Yes, I agree that he should stop smoking. He should try to improve his oral hygiene by
Oral hygiene,
antiseptic
mouthwashes.
mouthwash. Okay. So at the same time, you should start planning your treatment. So
Yes,
what should be your plan for treatment in this patient who has got T2N0M0
I
on
would
the
like to
background
do.
of well differentiated SCC?
I would like to do, sir, wide local excision,
How wide is wide?
sir, with 1 centimeter margin.
Fine. So if you do a 3 centimeter lesion, if you do 1 centimeter all around, you are almost excising 5 centimeter. Okay? If you do 3
Yes, sir.
centimeter, once on the up, once on the down, so it becomes 5 centimeter excision. It's a large defect in the buccal mucosa.
Yes, sir.
So how do you manage that? You have done
Sir,
a wide excision, okay, and then how are you going to manage this?
followed by flap reconstruction, sir.
What flap? How can you reconstruct this defect in the cheek?
Flap, sir, we can have local flaps and we can have free flaps.
Yeah,
Local flaps we can take from buccinator muscle flap, tongue flap, or nasolabial flap, or we can take PMMC flap, that is pectoralis major mycutaneous flap. Whereas free flap, we can take radial artery forearm flap or lateral thigh flap.
good. So you need not know details about these flaps. So the point is, if the defect is less than 3 centimeter, you can manage with the local flaps. Otherwise, you need to a major reconstruction of this buccal mucosa.
Yes, sir.
Okay? You
Yes, sir.
said the node is N0.
Yes, sir.
So in the background of N0 node, is there a role for addressing the lymph node at N0 status? There are
Sir,
two groups of
in
people. There are some proponent who said you should do a elective lymph node dissection. What do you mean by elective lymph node dissection?
so elective lymph node dissection means supramoid neck dissection we
Then
have to
what
do
does
that.
it mean? Supra or whatever they come next.
Types.
What do you mean by elective node dissection? And what do you mean by therapeutic node dissection?
So it is the elective node dissection. It's a diagnostic neck dissection.
That means N0. You have done investigations, you have done clinical examination, investigation, the neck was N0. So one proponent people are saying that in N0 neck, you can wait and watch. Number one. Second group of people say that even in N0 neck, there is a chance, there is 10 to 20% chance that the node might be metastatic.
Yes.
So there is a concept called elective node dissection. That means you are doing dissection of the node on the background of N0 neck. That is elective node dissection. And if you are considering doing elective node dissection, how far you will dissect? What is that dissection called as?
Supramoid.
Supramoid. Okay? Or selective node dissection.
Selective. Like,
Okay? Supramoid means what lymph nodes it takes into dissection?
Sir, in supramoid, level 1, level 2, level 3, along with
Yes.
submandibular gland.
Yes. So this is a selective node dissection. Okay, but if you see that this patient has got a palpable node which is suspicious of malignant deposit, you have some ultrasound done, suspicious, clinically suspicious, but uh, uh, this node enlargement in a patient has got a oral cavity cancer often can be a infective node. How do you differentiate?
Reactive lymph node it could be because poor oral hygiene.
So 50% of them would be infectious and 50% of them malignant would be there.
I'm trying to say is if it is an infective or a metastatic
How do
node,
you differentiate?
how do you differentiate?
So metastatic lymph node on clinical examination would be fixed, hard to
Not
stony
always.
hard.
No, it cannot be fixed always. A metastatic node which is not having external extension will be mobile. Try to understand. And sometimes it is difficult to differentiate a infective versus a metastatic node.
If it's
Okay.
infected, what you can give?
Radiotherapy.
No. Infective node.
Sentinel lymph node biopsy.
No. That concept is
Infection.
there.
What
That
infection can occur commonly? Oral cavity.
Tuberculosis.
Huh?
is there a role for giving this patient antibiotic?
Back.
Yes, sir.
Yeah. So point is, if you have a strong suspicion of a neoplastic node, you can do a image guided FNA. You can do a ultrasound guided FNAC that gives a confirmed diagnosis of a metastatic node. And if you feel that is a tender node, is a soft node, and it can be infective node, there is a role to give this patient antibiotic for about 10 to 15 days
2
and
weeks
then
of
review.
trial. Antibiotics trial should be given 2 weeks.
Okay, but if it is a strongly suspicious node, FNAC.
Yes.
Image guided FNAC can confirm. Suppose the nodes are involved on that particular site. What treatment will you offer for the lymph node?
Modified radical neck dissection.
What do you mean by modified? What is done radical node dissection and then come to modified?
Radical node dissection includes level 1 to 5 lymph nodes, along with submandibular gland and tail of parotid, along with sternocleidomastoid muscle, internal jugular vein, and spinal accessory nerve.
Good. So that is a standard radical node dissection which is being done for malignancy for very long period of time. Subsequently, people come with the idea that all these need not be sacrificed because once you sacrifice all these, patient has neck deviation because of the sternocleidomastoid. If you are doing bilateral dissection, you cannot tie both the internal jugular vein on both sides. One side IGB has to be preserved. So what are the different modifications? If you go say that it's a type 1, type 2, type 3, what does it mean? Type 1
Modified
modification is?
RND1, MRND1 would be we are saving only the spinal accessory nerve.
Good.
In type 2, spinal accessory nerve along with internal jugular vein. In
Good.
type 3, sternocleidomastoid, internal jugular vein, and spinal accessory nerve. All
Yes,
are preserved.
all three. So all three can be preserved and you can do a good dissection. So that is that. Now, patient says that he does not want surgery. You said you need surgical treatment and he said he does not want surgery. Is there any alternative treatment for such lesion?
Yes, sir. So as this is
What?
a well-differentiated squamous cell carcinoma, they are radio sensitive. So I would like to offer the patient radiotherapy as another option.
When you will not consider giving patient radiotherapy, there are some
When,
situations, even if he wants, you cannot offer him radiotherapy because there are some situations where radiation may not be effective.
sir, in the cases of when the patient has already developed orocutaneous fistula, radiotherapy is contraindicated.
And
In the when the patient has when the carcinoma has already eroded the retromolar trigon, we would not give the radiotherapy.
no, that soft tissue is not the situation. If the growth is invaded in the mandible,
Mandible.
you cannot irradiate the mandible. Okay, that will cause mandibular necrosis. So, bony involvement is an contraindication for doing your only radiotherapy for a primary treatment. Okay.
Yes, sir.
So, what is the role of neoadjuvant therapy in head and neck cancer, in oral cavity cancer? You know what is neoadjuvant therapy?
Yes, sir.
What is that?
Chemotherapy given before the treatment is known as neoadjuvant chemotherapy.
Uh,
So chemotherapy tends to make the tumor ratio sensitive more. So we would like to give in T3, T4 lesions.
yeah. So, in advanced lesions, when the tumor is large tumor invading into the adjacent structures, there is a role for giving neoadjuvant because even in head and neck cancer is well established now. Okay. Uh, so, what are the different pre-malignant lesions in the oral cavity which can lead to cancer?
So we can divide the pre-malignant lesion into three risks: high risk, medium risk, and low risk. High risk, we have erythroplakia, proliferative verrucous leukoplakia, and chronic hyperplastic candidiasis. Intermediate risk or medium risk can be we have two: oral submucosal fibrosis and syphilitic glossitis. And low risk we have three: oral lichen planus, discoid lupus erythematosus, discoid keratosis congenita.
Good. Oh, Kishan, we have gone beyond 1 hour. So,
No, that's okay,
too
sir. We
much.
are just joined by a great oncosurgeon from UK. They're straight from
Oi.
UK, sir. So
so,
wanted to welcome her. I
so Priyanka should
requested
come to know
her.
now.
We have with us our own, again, mentor of White Army, legend's daughter, Dr. Priyanka Saha, who is an oncosurgeon, who is doing her breast surgery, this thing in NHS London. Welcome to you. We have already given in the beginning, Priyanka, but we are seeing you at the end of the discussion anyway.
Yeah, I'm
We
so
want
sorry. Yeah, I would love to join sometime if you arrange a
surely,
day.
surely, surely. We'll
Yeah.
arrange a separate session for you in the weekend. Okay.
No, no, he is
Uh,
a MBBS student, but he
Good.
answered like a PG.
Better
So,
than a PG. It was a
yeah, yeah,
wonderful
yeah.
discussion so far.
Yeah,
If you
really, very
take in
good.
and ask him two difficult questions from oncosurgery level, it would be great then, because we could not ask him any question which he could not answer. We failed really. But you ask him at the end to make him study more and better. You ask him two difficult questions now. If this patient presented with dysphagia, what does it mean?
The dysphagia, then
Trismus, you already answered, no? If the patient has trismus, that means what is infiltrated into
pterygoid muscles.
pterygoid. If it's the same patient has got dysphagia,
The dysphagia, the most commonly present patient would be, I would be suspecting the posterior one-third cancer of the tongue.
no, in this
That is
buccal
the,
mucosa, threats to
excuse me, sir, I can't get it.
in this case, if this buccal mucosa malignancy, if it's presents with dysphagia, spreading into where? Retromolar trigone.
Trigon.
Okay. So Priyanka, we were discussing about the buccal mucosa case, CA buccal mucosa. If you have any questions already, you can ask him directly. Sir was asking about pre-cancer condition, very important. Okay, that one particular chart is very, very important. What you told is absolutely right. Excellent answering. Sir, anything else questions?
No, I
This is
think
it's
here
going really well. Last 10 minutes, sir. Please, 10 more minutes because we are learning a lot from this discussion. Yeah.
Have we discussed about the surgical planning?
Yeah.
Yeah.
That is asked in detail.
Yeah.
All the neck dissections, everything discussed, and all the different types of.
And
If
we
you
have
want
not
to
asked
add
about the
anything,
flaps because MBBS student, he is not supposed to answer the different details about the flaps. He said, but a area of less than 3 centimeter can be managed by the local flaps, by the buccal mucosa flaps or tongue flaps. But larger defect, this patient has got a 3 centimeter lesion. So you have a defect about 5 centimeter, which is quite big defect, which needs to be covered by a flap.
Yeah. Can you discuss about some of the reconstruction options in this gentleman?
He can, but you have to answer. He is an MBBS student.
no,
Of
Raghav, you can
Yeah.
try answering. He's already answered, I think.
In my patient or in general, sir?
So in general, you tell. In general, what are the reconstructive options available for CA buccal mucosa?
Sir, in the very small lesion, we can do wide local excision with the primary closure. And then we can wide local excision, then we can let it open and heal it on its own by the granulation tissue. Then we can have local flaps where nasolabial flap, tongue flap, buccinator flap, or PMMC flap, that is pectoralis major myocutaneous flap, we can take. And then free flaps we can take, that is radial artery forearm flap or lateral thigh flap.
You see, here you need 2 linings.
Yes,
if you are
sir.
doing a full thickness cheek excision, you need a lining on the inner side, you need a lining on the outer side. Clear?
Yes, sir.
So how do you achieve the lining on either side?
Sir, in the inner side, I would like to take the linings which do not have the hairs on it.
Yes.
Whereas in outer, we can take the sebaceous gland and all hair part because it is skin only.
But that's what I'm saying. Suppose you are trying to reconstruct a cheek with a large defect and you need to have a inner lining and outer lining. When you are using a radial free forearm flap, you can use the same flap and you can achieve both inner and outer lining with the same free flap.
Yes, sir.
If you are using a pectoralis major myocutaneous flap, that flap can be also used to cover both inner and outer lining. Earlier, people used to use a forehead flap.
Yeah, I think it's quite it's nowadays not commonly done.
Yeah.
So for the reason I asked you about the reconstruction of oral cavity cancer, because because when you complete the surgery, it's always quite a complex kind of a defect. So it's usually a combination of defect of soft tissues along with bone. Yeah, and then we have to plan where we can replace both the bone and the soft tissue. So if you have a defect of both bone and soft tissue, the best option is the gold standard is still the free flaps, especially the free fibula flaps. And then when you come to if it's only a soft tissue, then we can discuss more on the local flaps like a nasolabial flap, a temporalis muscle flap, trapezius flap, and you have a pectoralis major myocutaneous flap. And of course, leaving the area raw is not the I don't think it should be the first option, because when you leave that area raw, most of the times you see a lot of contracture and it leads to trismus. So you can put a
Some reconstruction has to be done, either by local flap or by some distant flap.
Yeah. You can also give an option of a buccal cavity fat pad placement, follow with a collagen cover. But usually all this has given rise to a lot of trismus. Okay.
Priyanka, recently I had a patient of this suspected submucosal fibrosis with pre-malignant condition. So I have done an excision of it and had put a skin grafting. But later on that he has developed trismus now. So I had suggested him all exercises now, but still, how could have been prevented? It could have been prevented.
Yeah, that's what I'm saying, because the general teaching of keeping the area raw or putting just a graft, usually they create a lot of contracture in the later stage. Yeah. Okay. So,
In that case, there should be a local flap, like a tongue flap or a buccal mucosal flap.
No,
Yes,
only
sir.
superficial excision, no, sir. For that, the flap is really required.
Oh, acha, superficial excision.
yeah, you can try putting some buccal fat pad with a collagen cover, but yeah, it usually creates a lot of contracture later on. Yeah, just
Because it was
one.
submucous fibrosis anyway. When you touch it, it proliferates. It's more. It becomes irritated and
Yeah,
gives
yeah,
more
yeah.
proliferation.
It's
Is that
already
the
inflammatory and with a fibrosis condition. Yeah. Just one last, just a question.
Yeah.
Since we are talking about trismus, do you know any device that can be used by the patient if they develop trismus?
Raghav?
No, ma'am.
Okay, it's just for the information. There's a thing called trismus screw that can be used by the patients. It can be given in the outpatient. You can just read about it. It's quite.
What we give is ice cream spoons. We can't tell
Yeah,
them to keep them
yeah,
in
yeah,
between. Slowly, gradually, it keeps on like expanding the whatever the mouth contracture is, the trismus.
yeah.
That's a common exercise we do in village, like in our second to tier 2, tier 3 cities, maybe. Is it
Yeah,
okay?
yeah, it's all right. Just that they have to move so that the inter-incisor distance, all any exercises that improves that. Yeah.
Correct.
So, Raghav, one question for you. Can you tell me one causative factor that is most commonly seen in the Indian population which leads to this submucosal fibrosis?
Betel nut.
Yeah. And can you tell why?
Because, ma'am, betel nut has alkaloids, that is ericolin and tannins.
Yes,
Ericolin is responsible for hyperproliferation and stimulation of the fibroblast and collagen, whereas tannins causes the stabilization of collagen, thereby causing pathogenesis
yeah.
for oral cancer.
Yes, it usually betel lives with a lime, that flaked lime. Yeah, that lime
Yes, sir.
usage in the Indian population, which leads to this thing. Okay.
Most common oral cavity malignancy, Raghav.
In India, sir.
No. See, you can't ask me cross questions. My question is simple.
Okay.
Most common oral cavity malignancy. That means what? It's overall.
Lip cancer.
Huh? No.
Lip.
Overall means in the worldwide, CA tongue more than CA lips. Okay. Then comes the in India. In India, which one?
Indian oral cancer.
Yeah. Yeah. Which is most common Indian oral cancer?
Gingival buccal skin.
Buccal mucosa. Buccal mucosa
Okay.
is more than the tongue. Okay. That's the one
Yeah.
thing. Mhm. No, sir, anything else you want to add, or else we
No,
can?
no, no. He has answered very well. I'm very
Everything.
happy.
He's answering everything. There is no use
Yeah.
asking the question also,
Have
sir, because
have we
Priyanka.
touched upon any of the adjuvant
Yeah.
therapy?
Chemotherapy, radiation,
We have
sir.
not asked about details of chemotherapy, but he could answer that adjuvant therapy is new adjuvant therapy. He could say that in T3, T4 tumors.
Okay. Okay. So, Raghav, just one quick question. Do you know anything called metronomic therapy?
No, ma'am.
Okay. So
Is
you
it
can
same
read
as
about
that of?
what?
Is it? Ma'am, is it same as that of immunotherapy?
No. So, metronomic therapy, uh, it's a different way of administering chemotherapy, okay, which gives a sustained response, and usually it is approved as a way of bridging therapy, and in some patients as a way of palliation. You can read about it. It's really
Hmm.
Like I learned about it when I was doing my MCH, but it's a very interesting concept of metronomic chemotherapy, how it works, and like how are we doing. There are a lot of studies coming from the Tata Memorial Mumbai AIMS Delhi. You can read about it. Okay.
Yes, sir.
Okay, thank you, Kishan. Thank you.
Sir,
It was a nice session.
concluding remarks about the oral cavity cancer and about the presentation, sir.
Yeah, regarding the you see, the most of the time in a MBBS student, you will get this as a short case. So you should prepare like one paragraph. You prepare like a one paragraph, give their salient points in history, salient points in examination, and then you will not be given a long case like a PG student in your exam as a long case. So basically, you should be you have mentioned all the points. Basically, you should be inquiring about the smoking, alcohol, and then dentures,
Ill-fitting dentures, yeah.
ill-fitting dentures, and whether he has got any traumatic lesion which is there for a long time,
Yes.
any chronic irritations. And then on examination, you should be uh, describing the ulcer clearly. You see, most of the students cannot describe an ulcer. You have described the ulcer nicely. So that is how a description should come. And then when you give an diagnosis, you may skip now saying T2, T, or whatever. Because once the exam starts, what is the T staging? You have to say, defend that, sir. Now T staging is also added with the depth of invasion. So it is not possible to give the depth of invasion on clinical examination. So I have not put my T diagnosis in this patient. I'll do the T staging after my investigations. Okay. And then regarding the planning of treatment, you should uh, stick to the staging. It is difficult to remember the stage 1, stage 2, stage 3, and stage 4, ABC. It is very difficult. You cannot remember all these points. But you should at least go to this TNM staging T, N, and M. And then obviously T3, T4 are locally advanced disease. The patient may not be a candidate for upfront surgery. And the way you answered is very good, that once you are asked how will you proceed with this patient, the answer should be investigation to confirm the diagnosis, investigation to stage the disease, and investigation to assess his fitness for anesthesia and surgery. So that should be the approach for any case. And then you keep on describing what are the investigation. As I said before, you said that imaging first and then biopsy, but again you are not sure about the diagnosis. The point Dr. Kishan raised out is breast. In breast, uh, sometimes you may not need a biopsy. You feel a lump and that lump was a fibroadenosis. You may not require a biopsy. So
Correct.
in breast, imaging is first. But once we find a ulcer lesion in the oral cavity, this is a lesion which needs to be proved is a benign or malignant ulcer. So
Correct.
first is biopsy. If it is a tubercular ulcer, we will not go for imaging. We start on antitubercular therapy. So that is a difference in approach in different areas. Okay, but otherwise you answered very well. I am very happy.
Priyanka, anything you want to add as concluding remarks about the cancer? Madam is from AIMS, okay. She did from grants and then went on to do MCH from the AIMS. Now she's in NHS. Priyanka, anything you want to add?
Yeah. Sorry, I could not hear you. What did you say?
Anything from your side as concluding remarks about the oral cavity? What undergraduate student should know, or how important it is to know?
Yeah, so like we have discussed, I think a lot of times, it's always to start with history. Like we have to make sure that while taking a history of oral malignancy, you do not miss out on the addiction, you do not miss out on any of the risk factors. A little, just a simple one word inclusion of family history will be nice.
Yes.
And after that, when you go for the examination, I think in undergraduate it's a bit daunting to get such a case, but the main thing that we have to understand is what we need to do is just to describe the ulcer.
Correct.
Okay.
Yeah.
And other than that, of course, when you're describing something of the oral cavity, you have to talk about the hygiene, you have to talk about the things like any staining of the teeth, any dentures, and
He did it very well. He
yeah,
did it
exactly.
very well.
Yeah. Yeah, it's just for the others. He's already a gem.
Yeah.
It's just
Yeah.
the ones who are listening, so that
We
because
will
because
lymph
I
nodes
know,
also. lymph nodes examination has to be done.
Yeah. Overall, and also we should not miss out on the neck. So because a lot of times when we see the Indian population, they come with big nodes in the neck, and that is the only presenting feature.
Correct.
And then when you do the endoscopies and everything, then you find a lesion somewhere. So
Yeah. That is a different entity. Unknown
Yeah.
primary.
Yeah.
Metastatic node with unknown primary is again a big area for discussion.
Yeah. So it's just that to complete the thorough history and examination, I think that is the key. And just to know that how to plan and what are the basic investigations is just after completing history and physical examination. First, if you want to do an imaging, next, of course, you need to prove it's a malignancy with a punch biopsy or or incisional biopsy. And after that, you come to the treatment, planning, staging, and adjuvant, if any. That's all.
Okay, Raghav, last question. A patient having a growth invading the mandible is required to resect the mandible. So how can you reconstruct the mandible itself? Only mandible reconstruction.
Yes, sir. So we can take free fibular flap,
Yes.
and then even iliac crust flap can be taken.
Rib. The next
Yeah,
choice is rib.
rib graft and a radial osseous
Yeah.
graft can be taken.
Yes. Good.